I'm going to be flexible with my presentation and try to maybe ask some questions and look at you and see what parts would be more relevant, because you've been very interactive and obviously very interested in Mary's presentation, where many of you have a background in mental health. So I was very happy to spend more time with that. But I'm trying to figure out how do I do it in 12 minutes, but we'll see how it goes. I'm going to share thank you very much. So the title of my presentation is about how nurses and midwives lead chronic disease prevention. I'm going to focus on the case of tobacco control, but some of the principles we're discussing can be applied to other chronic disease prevention. And I'm going to talk a little bit about why focus on tobacco control, why is it important, and then illustrate this with some examples of work of research that we're carrying out at King's College London. But it's a challenge to do it. So I'll try to gauge how much interest there on the different parts of the presentation. But why are we focusing on chronic conditions leading as a topic and the nurses' roles in that? And because we've switched from infectious disease to being an important cause of death to chronic conditions now being the leading cause of death worldwide. So 7 in every 10 deaths worldwide are caused by chronic conditions. And they're often avoidable causes. So we're talking about cardiovascular diseases, chronic respiratory diseases, cancer, diabetes, and mental health conditions as well. So hopefully this presentation is relevant to many of you who will be working with people or researching or studying those chronic conditions. And it links to sustainable development goals. In particular, we want to reduce mortality from non-communicable diseases and promote mental health. So nurses and midwives have a key role in helping people to adjust the way they live so they can enjoy happier and healthier lives. So linking to those chronic conditions that we see, why were we focusing on mental health, on smoking? Because we can see how tobacco smoking, affects all these parts of the body that is related to those chronic conditions that we've talked about: the heart, the lungs, circulation, fertility, brain, but also mental health, we've alluded earlier. So we know that people living with mental health conditions are 2 or 3 more times more likely to smoke, but also this is a vicious circle. So people who have mental health conditions are more likely to smoking, but smoking leads to poor mental health as well. So this is a vicious circle that contributes and is really relevant. And we know that the smoking prevalence among those who have living with mental health conditions is much higher compared to the general population. So if we want to tackle, we know that smoking leads to chronic conditions, and if we want to tackle reduce the death burden from chronic conditions and mental health, we need to be considering tobacco smoking. So what are the figures? Why are we looking at this? So worldwide, tobacco kills more than 8 million every year. And 1 million of those deaths worldwide are caused by secondhand smoking. So not only affects those who actively smoke tobacco, but those who are exposed to this tobacco smoke. It kills half of those who have the habit. Okay, and if we look at numbers around the world, I know in the UK, 78,000 people die every year from smoking tobacco. In Thailand, 66,000 people die every year from smoking tobacco. That equates to 180 people every day. Every day, 180 people in this country die because of tobacco. And this is preventable because it's something that is not easy to stop, but if we can stop the people starting smoking and we can treat it, we can really have an impact on people's lives. And I'm sure you've chosen to study health and nursing or midwifery because you want to have an impact on people's life. And this is an area where you can have a huge impact. So what is the current prevalence in the world? Worldwide, the overall prevalence is around 19%. But as you can see in this map, the darker the color, the higher the prevalence, okay? So it's not equal. And I've done a little table here where you can compare prevalence between the United Kingdom and Thailand. And overall, the adult prevalence, the UK has reduced it to 13%. And Thailand is at 90%. But I found it really interesting to see the differences between male and female. So in the UK, we don't have such a large difference between male and female smoking. While in Thailand, it's clearly that the interventions need to be focused on male smoking, where you have a high percentage, almost 40% of smoking rate versus very, very small rate of female smoking. But looking at youth smoking, again, you have a higher prevalence here in between 10 and 14 years have access to tobacco smoking compared to the United Kingdom. This information comes from the Tobacco Atlas that is updated every 2 years by the World Health Organization. So if you're interested, I would recommend that you have a look, and it has more information about the country regulations, what the interventions that are available, and so on. So we can see that tobacco smoking doesn't affect everyone equally. We also, so not in terms of gender, for example, we've seen, but also quite across the world, and this is data from Great Britain. Most likely people who are more living more deprived conditions are nearly twice as likely, or 2.5 twice as likely to smoke. So not only has a huge effect, but it really affects those who more perhaps need the help. So we can see that people who live in deprived areas or have less education or less income are much more likely to stop, to continue to smoke. So why, these are, the number of deaths per day are shocking. And so why is smoking so addictive and why is so deadly? Do we understand? Do we know or not? So tobacco, is important to understand how it starts. It starts with maybe experimenting, sharing with peers, something new, but it's a very addictive, nicotine is a very addictive substance, and it absorbs really quickly from the first puff, goes very effectively through the lungs, through the circulation and reaching the brain. And once it's arrived to our brain, the nicotine receptors are activated and they release dopamine, and that provides a positive reinforcement because the release of dopamine is associated with good feelings that will teach the person, let's try this substance again. But also negatives reinforce because it's very quickly creates withdrawal symptoms. So someone who is used to have nicotine regularly in the bloodstream, after 2 hours, the levels decrease. And then what people normally refer, I need to relax, a cigarette will relax me. What happens is what we are dealing with the withdrawal symptoms. So once you have the nicotine again, you feel, as you would say, normal. You don't have these cravings, irritability, and so on. So I think if one message that we can take on from this session today, when we're talking to clients, with patients who think, I really need this cigarette, is understanding that they do have those symptoms, that you don't feel well if you don't have nicotine, if you need it, but actually it's not, help you generally with the stress. We've seen how nicotine and tobacco smoking worsens mental health. So we need to find a way to break this cycle, this addiction, so that people can have better quality of life and reduce those all the risks. So already in the 70s, Professor Russell, one of the leading researchers in nicotine, just said smokers smoke for the nicotine, but die from the tar and all the other substances. So it's really important that we separate this understanding. And one thing is nicotine and the addictive effects, but all the other things that come in the cigarette is all the other things that are increasing the risk of cancer, of cardiovascular disease, and all the other diseases, skin problems, dementia. I haven't gone through all the others, but there's a lot of effects. So what's really important is to know that most what smokers want to quit. Have you ever come across someone who says that, maybe not tomorrow, not the next, but in principle, there's a habit they don't want to have. But without help, you will find people said, "Oh, I did it cold turkey." We say in the UK, but it's very difficult. Only 4% of people succeed to stop smoking without help. But this can be doubled, and more than double, if you provide the right support. So with pharmacological help, with behavioral support, you can increase this to 30% success. Still not 100%. So that is how strong the nicotine, and normally it requires a few attempts, but just is a chronic relapsing condition that requires support. Okay, so what is the nursing role in smoking cessation and in tobacco control in general? So the World Health Organization already had one of the years in the 31st of May, focusing on the role of healthcare professionals. So we need to screen for tobacco use. So it's 4 o'clock already. I'm just going to go very quickly to the key things that we think we can do. Screen for tobacco use and readiness, educate patients about quitting, provide cessation interventions and referrals, conduct our own research in the areas, if you identified in your particular settings that there isn't an intervention. For example, we've identified that patients with diabetes, because they're worried about weight gain, if they stop smoking, they don't stop smoking because they think, oh, well, if I'm going to gain weight, my diabetes is going to. So we are developing an intervention that is tailored for the specific needs for people living with diabetes. The same way, for example, we've identified in the UK that those who smoke cannabis don't see themselves as tobacco smokers, but in the UK, cannabis is normally mixed with tobacco. So then they want to stop cannabis, but they find it really difficult. But they find it very difficult because they are addicted to nicotine, but they don't see themselves as nicotine smokers. So we've developed interventions. So anything that you identified with the people you work with, where perhaps there isn't an intervention that supports, that's where you can develop your own research around tobacco and smoking. Advocate for tobacco control. So any opportunities, if there is a smoke-free policy, but it's not being followed, are you an active agent to try to help people to follow the smoking policies, or to create smoking policies or changes? For example, I know in this region, tobacco crops and the growing of tobacco is really important for the farmers. But I know also the government is trying to help them to move to a different type of crops. What are the roles of health professionals on that? Or what are the opportunities to contribute to the advocacy for those implementations of those policies? So it goes beyond the one-to-one, conversations we might have with professionals, and support community efforts. So I've shared the presentation with the organizers, and I've got a lot of examples of research that we have done at King's, and we don't have time to go through all of this today. So I encourage you to have a look to the presentation and the different studies we've done, for example, on training that you can download for your students. If some of you are faculty and would like to give more information about to nursing students on how to support people to stop smoking, we have a free course that can be downloaded and adapted to your curriculum. That's something you can have a look at the different projects that we've done in here. And I just wanted to leave the presentation with this quote that I like from Linda Sorna, who is a leading researcher in the UK on nurses' role of smoking cessation, because we are, one of the biggest in terms of numbers of healthcare professionals. So if only half of nurses worldwide help one patient per month to quit smoking, more than 12 million smokers would overcome their addictions every year. And I think that's quite, as I said, it's a challenging condition to tackle. But if you think, I don't know how much is done in the hospital where you work, and if this is an area you would like to develop further or find out more, please have a look at the links in the presentation and feel free to contact me. I'm very happy to discuss it further. And thank you for your time. Sorry, it was very short, but thank you. Thank you. So in UK is divided in the different countries, England, Wales, Scotland. So it's slightly different by country, but I can talk what happens in England. We have a network of stop smoking services that offer free smoking cessation support that includes pharmacological nicotine replacement therapy. It includes behavioral treatments, and happens in primary care, but also in hospitals. So what is now, since last year, every hospital has to demonstrate that within hospital stays, they know how many patients smoke. Everyone during the hospital stay has been offered support to stop smoking, including pharmacological behavioral help. And that is linked to the support that they can continue to have when they leave hospital. So hospitalization is an ideal opportunity. Patients arrive to hospital, they cannot smoke because they are smoke-free. And it's the ideal opportunity to then, even if they were not planning, to show them that you can have a period of smoke-free that can be comfortable if you are, for example, receiving nicotine replacement therapy and the right support. And that hopefully they can continue with that effort they've made when they leave hospital. But that needs continuity, it needs systems. So you need to have staff that is aware of how to support them, medication if needed, and continuation of that support when they leave the hospital. But yes, we do have a network, and we are increasing the training that we give to healthcare professionals. So not everyone needs to be an expert, but everyone needs to know where to refer to the experts and what is the minimum advice. We call it very brief advice. So we ask people, do you smoke? We advise them and we refer them. And then if they don't want to continue, they can opt out. That I would not like, but we offer it to everyone rather than say, oh, would you like it or no, I'm not interested. Now we've realized that trying the support is important, and then they can always opt out if that's not the right thing. But to make a hospital stay comfortable, we do that. And we do that approach in antenatal care. We had a higher rate of smoking in pregnancy, and we've decreased it very much by offering it to everyone and independent of motivation, and it proves to work. Yeah. So yes, you're right. So for those, it's undergoing voting in the parliament at the moment, but the plan, it hasn't been fully approved, but the plan is to make those who were born after 2007, as you say, they will never be able to buy cigarettes or to smoke. And my personal opinion, I think knowing how harmful that substance, and know that you can go and buy it. Imagine going to a supermarket where you can buy, I don't know, a kind of tomato soup that says it kills half of the people who would eat it, but you can, buy it. It doesn't make much sense. So I think if we can remove the opportunity for that to be there, that would be ideal. But of course, we have to be very mindful of there's always the possibility when something is not legal that there is a black market that then is not regulated. There will still be all the people who are continuing to smoke. I think the aim, going to smoke-free generation, is an ideal aim, but it has to be done carefully. But being a mother of young children and thinking they will not be able to buy cigarettes, I think that gives me hope that I think is a good idea for the future. But you have to be very careful how to manage. And I think it's always this balance between individual freedom and how much does the government tell people what to do. But I think we do have a responsibility on a substance that is so harmful and so addictive, at least to control the way. There are other ways to take nicotine that will continue to be allowed, but it's not the combustible, is the burning the tobacco, which makes it really, really harmful. And I think it's right to limit some of type of like consumption of that tobacco. That's my opinion. Yeah, thank you. So what's in, I think is now recognized is is an addiction. So just, I mean, knowledge is important, but most people know that it's harmful. And so sometimes you can use the capability, motivation, opportunity framework to discuss that, how to change behavior. So having the knowledge and understanding, having the opportunity is important. So having access to support and services that provide the medication and behavioral. But I think not to, so behavioral support is really, so the key what works is behavioral support with most of the times pharmacological support to either medication that blocks the receptors so that you separate that craving and the need of nicotine with the behavioral change. And then once you've gone over those cravings, you can concentrate more on what are the different habits that you used to associate. But knowledge is not enough because most people know, and it helps, but I think it's very important to work on the behavioral and motivational interviewing seems to work as well. Why is it important for you? You know, everyone has different motivations. That's why sometimes pregnancy is a right time because people say, well, I'm not doing it for myself, I'm doing it for, you know, but then there is a big relapse after pregnancy that people restart smoking. So working in the individual motivations but giving them the right support from pharmacological and behavioral support is very important, and also be very understanding it's a chronic relapsing condition that is sometimes needs several attempts to learn. But when if someone tries to quit and they don't have enough support, then they think, oh, it's too difficult, or that didn't work, but perhaps wasn't done in the right way. So yeah, empathetic, understanding, and knowledge is not enough. It's more than that. Yeah, thank you. Okay, so I mean, do you mean, so for example, I mentioned the highest success is when you combine pharmacological help. Depends on trials, but I think you have some trials with varenicline and behavioral. 40%, 50% with the right treatment is the highest you can, yeah, so yeah. Yes, that's the highest you can, and when you try without, you just support, 4% succeed without any 4%.
40%.
4% without any support. So if a smoker says, I'm going to try to stop smoking, some people will do it, and 4% is the average success rate. With behavioral and pharmacological support can increase, and the highest percentage goes with varenicline and behavioral support. There's also high percentage on lots of number of people who succeed using e-cigarettes.
Yeah.
Electronic cigarettes, which is different in different countries. In the UK, we support the use of electronic cigarettes for smoking cessation. We don't support young people to start using electronic cigarette, which is, we don't want to have more people addicted to nicotine. But for those who have found it quitting smoking really difficult, because electronic cigarettes are an effective way to give nicotine. So that helps people to stop using the most harmful way that is the smoking, the tobacco. But electronic cigarettes are not risk-free, but it's a harm reduction strategy like you would use with other substance. So we are, in certain settings, we are recommending the use of electronic cigarettes for smoking cessation. And we find, because it's an effective way to release nicotine and it has some of the behavioral aspects of smoking, people who are very successful to stop smoking combustible tobacco, but then they use electronic cigarettes.
They recommend to use the nicotine replacement therapy.
Yes.
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 that is
Yeah.
as strong as
Yeah, the systematic reviews. Yeah, and even there are also Cochrane reviews that on the use of electronic cigarettes for smoking cessation as well. Yeah, but the gold standard pharmacologically would be varenicline is more effective than nicotine replacement therapy and behavioral interventions. That's the gold standard. Yes. Thank you. Thank you.